Hi, for everyone who just joined, I'm Ann Greiner, President and CEO of the Primary Care Collaborative, and I want to welcome you to our third Lunch and Learn of 2021. This is a new series that we launched this year, and we're pleased that more and more people are finding out about it and joining us to talk about some of the most important, recent, relevant primary care research, both clinical and health services research. And we, based on input from all of you, we learned that you like to talk about both of those at our Lunch and Learn session. And so we're going to be doing that again today. And we are also so fortunate to have authors of the two papers that we're going to be discussing. I'm going to turn this over to Noah Westfall, who is a program associate at the PCC and has been really staffing this work and leading this work. So over to you, Noah.
Thank you. Hello, everyone, and welcome back to the third Lunch and Learn. As Ann said, I am Noah Westfall. I'm program coordinator for the PCC and the kind of main point of contact for this project. So please email me if you have any questions or feedback. Before we get started, I just have a few general announcements. For those of you that are interested in primary care research, the PCC actually just released our 2021 evidence report in collaboration with the Robert Graham Center, Primary Care and COVID-19, It's Complicated, Leveraging Primary Care, Public Health, and Social Assets. And you can view the report and the release event on our website. We also wanted to share some of PCC's recent thought leadership on primary care in two recently published op-eds, one in Helio and one in Forbes. And so those links to those articles will be placed in the chat for you to review. Finally, Mathematica is hosting another primary care Twitter chat on December 16th from 2 to 3 p.m. Eastern Time. And we'd like to invite you to join the chat and help elevate the primary care policy discussion using the hashtag primary care COVID chat. So I would like to welcome back our two Lunch and Learn co-chairs, Dr. Irene Dankwa-Mullan from IBM Watson Health and Dr. Jack Westfall from the Robert Graham Center. They will be facilitating the discussion on our two articles today. And we have a great lineup of speakers to talk about the evidence on the patient-centered medical home and the current evidence for aspirin prescribing. So during the presentations, if you could please put your questions in the chat, and our co-chairs will plan to ask those questions of the speakers during the open discussion. Next I would like to turn it over to Dr. Irene Dankwa-Mullan to introduce our first speaker.
Great. Good day, everyone. So good to see you all. And I also want to echo Ann's sentiment. Welcome. I'm really excited today about our first paper that we'll be discussing, since it's centered on the benefits of the medical home. We all know that patient-centered medical homes are really driving important transformational changes in the healthcare delivery. And there's published evidence around how these medical homes promote quality of care, patient engagement, savings through coordinated care that really aligns patient preferences and values in shared decision-making process with a healthcare provider, and sometimes integrating payer capabilities, right? So there's definitely interest in the impact of medical homes, especially in quality of care, and for individuals with multiple chronic conditions. So we are really excited. We're going to hear from Dr. Karen Swietek, who is a senior health economist at NORC at the University of Chicago. She has experience in secondary data analysis, quasi-experimental study design, evaluating Medicaid programs, and her research has focused on the integration of primary care and behavioral health services, alternative payment delivery models, and racial disparities in quality of care. So, and since joining NORC, Dr. Swietek has actually published several multiple site evaluations for the CMS, and I hope we hear that as well. We're going to start with her paper, and then in the discussion session, we hope to hear sort of her current research because this was published a while back. So I will hand it over to you, Dr. Karen Swietek. Really, thank you for coming, and let's start.
Hi, good afternoon, everyone. Thanks for the introduction, Dr. Dankwa-Mullan. I'm really pleased to be here. I know many, but not all of you, but I'm looking forward to the discussion. So this study was published in 2018, and it looked at medical homes and their effects in patients that have multiple chronic conditions. Noah, could you advance the slides, please? Thank you. I'll just start by providing a little background on the motivation for this research. Managing multiple chronic conditions, I think we all know, has become a big priority for the US healthcare system. In 2018, when we published this paper, over 50% of adults in the United States reported having at least one chronic condition, and more than a quarter had at least two, which is known as chronic comorbidity. And research has shown us that having multiple chronic conditions is associated with poor health outcomes and a higher risk of death, and also higher healthcare costs. In fact, managing chronic conditions accounts for about 75 cents of every dollar spent on healthcare services in the US. We also know that this is largely because people with multiple chronic conditions have more complex healthcare needs, which makes sense. They use care more frequently, they access a wider range of services than the general population. They often require multiple providers across different specialties, and they're at increased risk of financial constraints and health-related social needs. So that's where the patient-centered medical home model of primary care transformation comes in. While there's no single recommended model of care for this population, there is a sizable and growing body of research that demonstrates that the medical home can improve quality for conditions that require long-term management. And in particular, it's the medical home's team-based structure and emphasis on coordination of care that might be really beneficial for patients with chronic comorbidities. Next slide, please. So at the time this paper was conceived, there were relatively few studies that examined the relationship between enrollment in a medical home and process quality of care metrics for people with chronic comorbidity. And the evidence that did exist was somewhat mixed, and also it was largely focused on adults in the Medicare population and older adults. So we designed this study of Medicaid enrollees in North Carolina. Our study population was made up of North Carolina Medicaid enrollees during fiscal years 2008 to 2010. They had at least 2 of 8 target chronic conditions that we selected based on high cost and high prevalence, and also availability of claims-based outcome measures. The setting was Community Care of North Carolina, which is a regional primary care medical home program for Medicaid enrollees. And beginning in 2007, CCNC created a specialized chronic care program specifically for folks with chronic conditions. Those services included things like disease management for multiple chronic conditions, increased access to urgent care. They co-located behavioral health care in primary care settings and implemented enhanced transition management. So that was our treatment group, was patients enrolled in a CCNC medical home for any part of that year. The comparison group was North Carolina Medicaid enrollees that were not in a medical home, so they were just receiving typical Medicaid fee-for-service in the state. We looked at 9 binary claims-based outcomes, and these outcomes were disease-specific, meaning they were only assessed for the subgroups of enrollees with the relevant diagnoses. So for example, for diabetics, we looked at A1C testing. For enrollees with schizophrenia, we looked at assertive community treatment. And we used linear probability models to assess the likelihood of receipt of each of those 9 outcomes. We included person and year level fixed effects to account for any time invariant confounders between the treatment and comparison groups. And we also included patient age and length of Medicaid enrollment during the year as our patient level time varying controls. Next slide, Noah. So on the whole, what we found is that the medical home is actually a really effective way to improve care for this population, at least from a process quality of care standpoint. Medical home enrollees were more likely to receive almost all process quality of care metrics for both the physical and behavioral health conditions that we looked at. For those with physical chronic conditions like diabetes or hypertension, they were more likely to receive almost all guideline recommended care that we looked at. We also included a couple of behavioral health conditions because we know that mental illnesses are the most prevalent comorbidities among the highest cost Medicaid enrollees. So in this case, we looked at major depressive disorder and schizophrenia. We chose those because there are well-developed treatment guidelines for those conditions. And similar to the somatic conditions, we found that medical home enrollees with the behavioral health conditions were more likely to receive the guideline concordant care. The one exception was that we found that short-acting beta agonist overuse among patients with asthma, medical home enrollees actually fared a little worse than their non-enrollee counterparts. But I do want to note on this one that because we are using administrative claims data, this measure only captures medication dispensing and doesn't look at actual use. So what that may be reflecting is actually just a greater propensity to have adequate or maybe even extra inhalers available for those patients. Next slide. So overall, this study adds to a body of evidence that suggests that the medical home is a pretty effective way to improve quality of care for complex populations like folks with multiple chronic conditions. And in the years since the study was published, a number of similar studies in slightly different settings and populations have produced similar results. And before I conclude the slides and open up the floor for discussion, I just want to mention a few considerations that aren't directly addressed in this study. We used a pretty flexible definition of medical home enrollment, so we required only that patients be enrolled at any point during the year. And the reason that we did that was to increase the generalizability of our findings, because we know that Medicaid enrollees often roll onto and off of coverage during a given year. But in a different study using the same data, we found that for patients with depression specifically, longer duration of medical home enrollment was associated with a higher likelihood of guideline concordant care the longer they were enrolled. So we saw this dose response effect, which might suggest that it's important to prioritize continuity when we're thinking about medical homes. Somewhat similarly, barriers to access are an important consideration that we didn't address in this study. There's a lot of evidence that not everyone has equal access to medical home programs, which may significantly limit their benefits. For example, we know that rural populations, racial and ethnic minority patients, patients with serious mental illness all have disproportionately low access to medical home programs. And somewhat relatedly, I just want to end on the note that it's extremely important to consider equity when we're talking about medical homes. This particular study we're discussing right now only looks at average marginal treatment effects among all medical home enrollees. It doesn't explore any subgroup effects or analyze disparities in either access or outcomes. And so in order to be a truly patient-centered model, the medical home really needs to be able to adapt to the particular needs of a diverse group. And it's becoming increasingly important that we specifically study which patients may benefit most and also least from this model. And that will allow us to tailor both the implementation and the evaluation accordingly. Next slide. So that's the end of my prepared slides. Before I wrap up, I just want to say thanks again to the Primary Care Collaborative for hosting this. I think it's a really important discussion series. And I want to make sure to thank and acknowledge my excellent co-authors. It's a really talented team. They produced a lot of thoughtful and interesting research on the medical home over the years. And I'm really glad to have had the opportunity to work with them. Thank you.
Terrific. Thank you so much. That was a insightful presentation, and I do want you all to could please put your questions in the chat, and we'll make sure that we address all these questions But I did want to start, and your last comment bullet in your PowerPoint presentations, you talk about equity being an important consideration. And you may have touched on it a little bit, but what would have been your follow-up? Have you had any, can you tell us a little bit about your current research looking at racial disparities in the medical home setting and what you found? I think you're on mute.
Yep, I muted myself. Yeah, absolutely. I think this is a critically important part of this discussion. And I have done some work more recently, specifically on disparities among people with major depressive disorder and comorbid physical conditions. I think I mentioned earlier that behavioral health conditions are one of the most prevalent comorbidities among the highest cost Medicaid enrollees. And also we know this is a really clinically complicated population to manage. And this might be especially true for racial and ethnic minority patients who experience mental illnesses at roughly the same rate, but they also have disproportionately high risk for chronic comorbidities. And they're more likely to seek their mental health care from a primary care provider rather than a specialist. So I think studying disparities in the medical home is a super important topic. So we've done a few studies that look at the effect on racial disparities. And what we found was that similar to the study we were just discussing and some of our other studies looking at the effect more generally, overall quality of care mostly improves. But we also found significant racial disparities in quality outcomes. And we found that the effect on those disparities of the medical home is actually pretty inconsistent. So in some cases, like specifically antidepressant use, we did see a narrowing of the Black, white, and Hispanic white disparities. But for other outcomes, we either saw no effect, or while both groups actually improved a little bit, the disparity either persisted or even widened. And this to me just suggests that equity needs to be a really important consideration, both for designing and implementing these models. And we have seen a trend in that direction. I know that some of the major accreditation programs like NCQA are including equitable access and outcomes now in their recognition standards. So I think this is a really important area to focus on going forward.
Great, yeah. So there's a question in the chat from Mark. How did you adjust for differences between choosing a CCNC and those not choosing to participate in one in your study?
So we included patient and year level fixed effects to address those differences. I mean, ideally, we would have liked to do something like a propensity balance. But since we were working with administrative claims data, almost all of the variables that we would have been adjusting for were time invariant in the first place. So we used fixed effects models to account for those.
Mm-hmm. Any sense of, this is from Serena, any sense of whether one component of PCMH had more impact than others? And that was a question about, yeah, what were the models?
Yeah, that's actually a really interesting question. My answer is no. The medical home in most research that we see these days tends to be kind of a black box. And a major challenge for evaluating these programs is that the criteria for recognition in most cases are flexible and the implementation is really varied across settings. And in some ways that's important because we need the model to be flexible, to be able to be patient-centered and to be adapting to the needs of specific populations, but it does make it challenging to identify exactly what the secret sauce is and which portions of the medical home are improving care for which populations.
Yeah, and perhaps the makeup of the provider, right? And sort of, so there are all those dynamics with culturally competent providers, the services that are required. And then a question about, how did you specifically look at language barriers and their effect on medical home benefits?
No, with the Medicaid claims data that we were working with, we were not able to look at language barriers. And that was actually, I think, a significant factor in some of the disparities research that we've done, because I know that a major driver of disparities, especially among Hispanic Americans, is language barriers and language concordance. And unfortunately, with administrative claims data, we're just really not able to assess that.
Mm-hmm. How are we doing on timing, Nora? We have a few more questions.
Yeah, we have time for a few more questions.
Yeah. Any other questions? If you were to actually, yes, Anne, go ahead. Oh, I thought Anne had a question.
Yes, I do. Thanks so much, Irene. And it's great. It's wonderful. Everyone's putting questions in the chat, but also if people want to ask questions, I think our group is not so huge that we can't also have that as a mechanism. Thanks so much for the presentation. And it's heartening to see the positive outcomes in almost every dimension, except for the one which you explained there may be an issue with. But I'm curious, the preponderance of evidence related to PCMH and chronic care patients, how would you characterize it in terms of strong evidence, kind of more middling evidence? I'm just curious about other research that's been done and how it lines up with what you've just reported on.
Yeah, I would say that the evidence for process quality of care metrics and things like preventative care is actually pretty strong and trending in a positive direction, although occasionally you'll see studies in specific settings or populations where it doesn't line up with that. What's interesting is I think that we're not actually seeing evidence that bears out that preventative care or process quality of care metric improvement is actually translating to improved outcomes. I think there's sort of a dearth of evidence on clinical outcomes specifically. And I do know that for things like emergency department use or inpatient hospitalization, those studies are fairly mixed. So I think we're fairly confident that process-wise, the medical home is pushing us in the right direction, but there's sort of a missing link about whether or not we're really translating that into improved outcomes.
Thanks.
And Jack has a question. Jack, I can read it. He says, bottom line, given the slow pace of payment reform, should we be promoting medical homes to our primary care practices?
Oh, that's a very good question. That might be above my pay grade, honestly. I mean, medical homes have already proliferated at a pretty rapid pace, but yeah, payment reform does need to catch up. We need to be incentivizing these models. And I think I would tie that back to Dr. Dankwa-Mullan's question about the which components of the medical home are actually the ones that are driving this reform. I think it's going to be important to identify, which standards are most important and which aspects of this are doing the most good before we start incentivizing them.
Mm-hmm. And Marjorie is asking, is there enough money to truly support full?
I don't think the amount of money supporting PCMH is enough to do what all we think PCMH is. And I thought of immediately an example. I hope you'll forgive me because it's from my past, but one year my university decided they're going to go into a capitated HMO. And one day we got 7,000 new patients because all the employees chose us, and the university thought that wouldn't happen. So that was pretty dramatic. But we saved $500,000 in that first year from their usual care costs by having the continuity at a primary care provider. That was the part that came to us. I don't know how much they saved. Now, of course, that meant next year they cut, a quarter of the money we were getting per person. But I do think PCMH, if you allow it to be the full thing it can be, is even more than what we're seeing now.
Yeah, well, the effects on spending are also a bit mixed because we see increases in outpatient utilization, which I would argue is usually a good thing and indicative of people getting care that they need. But we're also not necessarily seeing the flip side, the reduction in inpatient and ED spending. So it's, it's sort
I
of
will just say that a lot of ours was reduction in emergency use and inpatient spending.
Oh, that's really interesting. I haven't seen a lot of.
We set up our office so we had evening hours, urgent care come in pretty much any time in addition to our continuity practice. And I just think those things make a huge amount of difference in what you can accomplish. And when you have the whole family as well, I think that makes a difference. So I don't think that we've fully supported what PCMHs could do if we really release them to do it as well as they could.
Yeah, I agree. I mean, I think in a lot of cases, in CCNC's case, I know that they receive a very small capitated payment to cover things like extended appointments for patients with more complex needs or care coordination. And I think it's going to vary across settings. You know, if you have a relatively healthy patient population, that might be enough to expand your services. But if you're dealing with a very sick population or very complex population, then we may need to adjust that.
Yeah, we have another great question about what do we know about medical home benefits on patient-reported outcomes?
I have to admit that I am not very immersed in the literature on patient-reported outcomes. You know, experience of care is obviously a really important metric for this population. And in general, my sense is that people are happy with their medical homes, although this is actually sort of a difficult thing to study because a lot of people don't know that they're in a medical home. It's kind of on the back end. I happen to know I'm in a medical home because I signed up for one on purpose, but it's not, you know, posted anywhere at my primary care office. So sometimes it's a little difficult to tease out those effects.
Yeah, and have you looked at models like Oak Street Health? Is that a flavor of a medical home?
I am familiar with Oak Street. I have not studied them in
It's like
detail.
Marjorie is saying, yes. Mm-hmm.
But yes, they do, you know, I'm not sure if they're actually an accredited medical home off the top of my head, but I know that they do have things like enhanced care coordination, disease management, and just whole person care.
Yeah, great. For those of you are in medical schools teaching patient medical standard homes more aggressively? Yes, no, mixed?
I don't think much.
Oh.
It's dependent on the primary care groups to do it, and they don't have much time in the curriculum. And so it's haphazard what they get to experience on their rotations. I'd be happy to have other people tell me I'm wrong.
Jean has a comment here. I don't know if it's a comment about medical homes can vary a lot in the degree to which they achieve those core features.
Yeah, Gene Rich here. Yeah, I'm basically referring to the fact that that even the degree of actual access and the degree of interpersonal continuity of care can vary a lot in practices that, you know, that are certified as medical homes. And then of course, medical home certification, comprehensiveness of primary care isn't even a meaningful factor. So again, O'Malley has shown that practices that are certified as medical homes can vary in quite meaningful ways in the degree to which they deliver comprehensive primary care. So, you know, just being alert that being a certified medical home may not be everything about becoming an excellent site for primary care.
Yeah, and I would add to that one challenge in evaluating the medical home is just that it's sort of hard to tell whether it's the accreditation and the transformation of the medical home specifically that's causing this change in outcomes, or if those practices are already doing those things and are already operating at sort of a higher level and are just more likely to get certification to begin with. It's difficult to tease that out.
I'd say it's some of both.
Yeah, we want to begin wrapping up, but I've seen a question from Mark Ringo. Are you there? Do you want to?
Yeah, shall I explain?
Elaborate? Yeah.
So
evidence around the medical homes.
I learned from Jack Westfall a long time ago that rural practices in many ways were already, where I've spent a good deal of time, rural practice are in many ways already medical homes. And it worries me to see with the ever increasing industrialization of healthcare, you know, if you can't measure it, you can't manage it, more and more standards and a higher and higher rate of burnout. And we're not really, as what you've said so far is that we haven't really shown in any definitive way that we're getting better patient outcomes. We're getting better adherence to ever more standards, but are we getting in the way of the relationships between patients and providers, which are the very fundament of primary care? That's my statement and question.
Yeah, I mean, I agree. I think, yeah, sorry, I'm trying to think of how I want to phrase this. Yeah, I do think that, especially since we have such a plethora of ways to accredit medical homes. I know that the NCQA is the most common one, but there are just a variety of incentives. I think that we need to think about how we're aligning those. And we need to think about what the actual burden on the practice is, because in some cases, like you said, practices may already be doing those things, but just the cost and the burden of accreditation is too high. And so they're going to focus their resources on providing patient care rather than going after like an NCQA recognition, for example. Does that speak to your question?
So I've gotten a
Thank you.
note that we should wrap up here, but definitely great questions still in the chat, and we can respond there. So I'll turn it over to my co-chair, Dr. Westfall.
Thank you, Dr. Dankwa-Mullan. Jack Westfall here, family doctor. So exciting to be here. It's really fun to be able to introduce this group. A comparison of contemporary versus older studies of aspirin for primary care prevention. I'm particularly excited to introduce Dr. Mark Ebell. I've known Dr. Ebell for 20 years, and it's really fun to watch his internal angst this year as Georgia is playing Michigan in football. As an Ohio State fan, it's just fun to watch him suffer a loss, no matter how that game turns out. Dr. Ebell is a graduate of University of Michigan Medical School, Family Medicine Residency and School of Public Health. He's currently a professor in the Department of Epidemiology and Biostats in the College of Public Health at the University of Georgia. He's editor-in-chief of Essential Evidence and deputy editor of the Journal American Family Physician. He is author of over 500 peer-reviewed articles and is author or editor of 8 books with a focus on evidence-based practice, respiratory infections, and clinical decision-making. He served on the U.S. Preventive Service Task Force, was a Fulbright Scholar in Ireland, in Dublin. His compatriot, Dr. Moriarty, is a pharmacist and senior lecturer at the School of Pharmacy and Biomolecular Sciences. He is also a visiting research fellow at the Irish Longitudinal Study on Aging and is lead of the Medications Working Group. Was a previous senior scholar at the Center for Primary Care Research at the Department of General Practice. He completed his undergraduate at Trinity College Dublin, and his doctoral research focused on the impact of potentially inappropriate prescribing on economic and patient outcomes. I will turn it over to this team to present our paper, A Comparison of Contemporary versus Older Studies of Aspirin for Primary Prevention.
Thanks, Jack. Yeah, go blue, I guess is my mantra these days. And it's great to be here. What a nice group and so many familiar faces and names that I see on the screen. So thank you for inviting us to speak. One of the great joys of my Fulbright, which happened in early 2019, was getting to meet Frank. I didn't know about him or know him before I got there. And we found while we were having just casual conversations that we were both interested in this question of what's going on with aspirin with all these new studies. And I also just noticed that both University of Georgia and RCSI were founded in 1784. I hadn't ever made note of that. So 2015, I was on the task force when we voted on this, and the original and that guidance at that time was a B recommendation. So you really ought to do it for primary prevention of patients 50 to 59 or 60 to 69. It can be a shared decision if they're at increased cardiovascular event risk. That was based in significant part on the earlier studies. In fact, we only looked at these studies before 2000 when making that recommendation. And it was also based on the fact that it was a clear reduction in colorectal cancer incidence and possibly mortality. The most recent update has downgraded from a B to a C for 40 to 59 and to a D for those 60 and older, which means D for don't do it. The ES and that guideline incorporated the newer studies, but still looked at the older ones. The European Society of Cardiology in 2016, looking at these newer studies, came down and changed their recommendation, and they no longer recommend aspirin for primary prevention. So why is that? Our hypothesis is that these Newer studies were done in just a different context, a different era. We're doing a much better job. We could be better, but we're doing a better job of managing hyperlipidemia and hypertension and diabetes. Back in the 1970s and 80s and even 90s, there was relatively little colorectal cancer screening and other cancer screening. So we wanted to compare these old studies with the new ones. For the older studies, there was an individual patient data meta-analysis with 95,000 patients. They recruited patients between 78 and 98 and published their studies during that time frame. There was also an aggregate meta-analysis that we looked at for some of the outcomes. We then looked at the newer studies, and you can see they were published between 2014 and 2018. They had a variety of inclusion criteria. Some included only diabetics, some no diabetics. They were generally older adults at moderate or higher risk for cardiovascular disease, and they were done all over the world. And as you can see, they were adequately powered. These were pretty big studies, about 60,000 patients in the newer studies. And they all recruited patients after 2005. So this is we are contractually required as meta-analysis to include this. Bottom line here is that the studies were well designed. Lots of green means they were generally well designed with a little risk of bias. The Japanese trial was an open label trial. That was the only ding against any of these studies. So here's some of the results. This is focusing on benefits in terms of mortality and the major adverse cardiac event, or MACE outcome. So toward the top, you can see all-cause mortality, the relative risk. Focus on those little diamonds. They give us the overall estimate. And the more that diamond sits on that vertical line, the more it means that there's no benefit. So there was no benefit in terms of all-cause mortality, no significant benefit for cardiovascular mortality, perhaps a trend toward fewer fatal MIs, but no difference in fatal strokes. And there is some heterogeneity, but when you look at the composite of MACEs, it was just barely statistically significant, but there was a benefit if you add up the deaths, non-fatal MIs, and non-fatal strokes. So there is some cardiovascular benefit in these older, moderate to higher risk patients. But you also have to consider harms with aspirin. When you're telling someone to do something for the next 10, 20 years, that's an important consideration. And we saw a significant increase in the risk of intracranial hemorrhage, major hemorrhage, and a pretty strong trend toward more fatal or non-fatal hemorrhagic strokes. This shouldn't be surprising to anybody. We'll put this into absolute terms at the end of the presentation. Now, this was, I think, most eye-opening in some ways. So for cancer outcomes, there was the trend toward greater incidence, greater mortality. And remember, the older studies showed some benefit, and we'll compare those in the upcoming slides. But instead of preventing colorectal cancer or reducing its mortality, we now see that it seems to have an adverse effect. And the aspirin trial in particular here had a significant increase in the incidence of colorectal cancer. The Japanese, in death and mortality. And the Japanese primary prevention program trial saw an increase in incidence. And all of the point estimates for the studies, other than this one at the very top, the ASCEND trial, were to the right and indicate a worse trend with aspirin. So comparing the older with the newer studies, what we see for the MACE outcome at the top is some attenuation of the benefit. We moved a little bit closer to 1, but there is still significant benefit. We see no difference in the mortality outcomes that's significant for either group of studies. We see bleeding outcomes are still an issue, and they're still significantly increased with the more recent studies. And then for cancer outcomes, before there was a significant reduction in mortality, now there's consistent and significant trend, I would say significant, but consistent trends at least showing harm. And you can see that for cancer incidence, it was nearly statistically significant. And then finally, comparing the old and new studies for stroke outcomes, I've highlighted a couple of things. There had been an increase in fatal hemorrhagic stroke seen in older studies that was not seen in more recent studies, so that's a good thing. There was no real difference in ischemic stroke, although it did become marginally statistically significant. And there was no longer a significant reduction in non-fatal MIs. So we see some things that have shifted a little bit, particularly the non-fatal MIs. And here's putting things into absolute terms. And in the far, what we've summarized here is the major adverse cardiovascular events, number needed to treat to prevent one event over typically a 4 or 5 year duration of the study is 300. To prevent an ischemic stroke is 400. On the other hand, the number needed to harm is in the same rough magnitude for intracranial hemorrhage, and it's lower, which is worse, for major hemorrhage. You only have to treat 143 people to cause one major hemorrhage. And in absolute terms, for every 1,200 people who are taking aspirin for primary prevention for 5 years, you'll see 4 fewer MACEs, 3 fewer ischemic strokes, but 3 more intracranial hemorrhages and 8 more major bleeding events. So our sense is that the harms were consistent between the older and newer studies, and that makes sense. There's nothing that's changed about human physiology necessarily. There's no longer any reduction in cancer incidence or mortality, which was an important consideration in recommending aspirin for primary prevention. There's a consistent decrease in ischemic stroke, although it's small. No longer any reduction in non-fatal MI. And on balance, we concluded that we agreed with the European Society of Cardiology that aspirin can't be recommended for primary prevention of cancer or cardiovascular disease. So that is Inishir, which is in the Aran Islands in Galway Bay, one of the most lovely places I've ever been. And I'm going to stop sharing and then happy to entertain questions.
Mark, thank you very much. Please, those of you who just listened to this, please put your questions in the chat. It's a pretty remarkable analysis and a very succinct presentation. So Mark, I'm going to start with a question. What this leads to is the concept of deprescribing. And I wonder if you and Dr. Moriarty could just give a little explanation of sort of how do you approach both the clinical scenario and the cultural sort of the culture of deprescribing in a society where more pills is better. You're now asking clinicians and patients to not take that pill that we have been telling them is the right thing for the last 3 decades. Describe a little bit about how that comes about in aspirin, in either your clinical setting or your own opinions on this, and then from a broader perspective of deprescribing for potentially other medications and treatments.
Yeah, I'm going to turn it over to Frank in just a second because he does a lot of work on deprescribing and potentially inappropriate prescribing, and that's, I think, more in his domain. But you know, certainly medical reversals can be challenging, and I still remember when the trials came out around hormone replacement therapy, and physicians felt betrayed by the scientists doing the research that had been telling them, and betrayed by their educators who had told them, you need to talk women into taking HRT. And then the better data came out, and those reversals can be difficult, not only for patients, but also I think for clinicians. But Frank, I'd love to hear what you think about this.
Sure, thanks, Mark. So yeah, I'd written down medical reversal as well as you're asking your question, Jack. So me and Mark on the same page there. I think it's part of it is, I suppose, that, you know, over time we do see evidence shifting on interventions, you know, we as researchers, clinicians, patients thought were effective. And I think, you know, I think it is that framing around the conversation when starting a medication that, you know, being honest that, you know, based on the current evidence, we think this will provide you with benefits over the time period you might be taking it, but also maybe setting expectations that I suppose, you know, an individual's prognostic factors, accumulation of other conditions, you know, is likely to change over time. And I suppose setting expectations for patients that, you know, there may come a time in 5 years, 10 years time where actually you will be better off not taking this medication than taking it. So I think a lot of the, I suppose, process of deprescribing could be eased certainly by at that initiation stage, setting expectations for patients that, you know, at some point in the future, you know, that they're not being given up on. It may be actually that they're better off not taking a medication that was previously beneficial for them.
Yeah, I almost see several kinds of reversals. There's the reversal that occurs when we didn't have good evidence, but now we have stronger evidence, like with HRT. There's the individual level reversal where, as you said, Frank, a patient gets older or they develop a comorbidity and it's no longer recommended that they take a medication or an intervention. And then the third kind is when you have societal or really more cultural, societal, larger forces at work, like we're doing better, we're doing cancer screening for colorectal cancer pretty well, not great, pretty well. And so that's in sort of the environment and the context. So there are a lot of different things that can lead to these reversals.
I'm struggling with this because I'm at the age where maybe I should be taking aspirin, and I'm hoping that aspirin is not like the wide tie, coming and going with the decades. Question about the race and ethnicity of the samples in both the early studies and in the later studies. Were there differences in the demographics of those samples? And could those be related to any of this? Or are there any sub-studies that show ethnic, race, gender differences among those samples?
So I'm not aware of any. Obviously the Japanese primary prevention program was in Japan and was almost entirely Japanese participants. The other studies were in the US, UK, and Australia. And while there was some diversity, it was predominantly white participants. I'm not aware of any other research that has broken out response to aspirin by race. Frank, I don't know if you've heard of anything like that.
No, I was going to say the same. I thought predominantly kind of white populations, and you had that kind of racial or ethnic differential effect. I'm not aware that it has been examined.
I mean, it'd be an interesting question, because I think also in terms of social determinants of health and sort of the underlying causes of health inequities related to social determinants, often there's an inflammatory hypothesis. So you could posit that perhaps there'd be a greater benefit, but I don't think we have evidence of that. But it's a really, really interesting and important question.
Kathy Pham says that the ACCP, they have shifted from the term deprescribing towards optimizing medication regimen. How is deprescribing as a term and a concept received by physician providers in your views?
Yeah, I don't know the answer to that. I know that there are some great YouTube videos that a Canadian pharmacologist does around deprescribing. I haven't sensed pushback against the term. Frank, have you encountered that?
No, like I think there's probably a balance, excuse me, to be struck between making deprescribing seem like something kind of special versus something that should just be, part of what happens routinely when someone's, visiting their physician and having their medications reviewed, and maybe actually something doesn't get renewed this time based on an assessment of benefits and harms and shared decision with the patient. So yeah, I think there's a few different schools of thought as to whether deprescribing is a good term to try and use or not.
Please take a look at Jetty Edelman's shout out to you, thanking you for this paper and this presentation, specifically around the challenge for rural physicians and pharmacists to have ideal decision support. She gives you a shout out. Thank you, Jetty, for that comment. Let's see.
If I may add.
Oh, please. Yes, add.
Jetty, thank you. Here at Texas A&M, I just want to add, as we all have watched what's happened with resistance to following the best practice, sometimes with what we've seen with this global pandemic and COVID, that there really is that challenge in the rural area for their primary care physician or their family doctor, which, if there is one in that tiny town or wherever they have that relationship, that it isn't as simple as changing a medication, because you're dealing with that belief that goes with something that they choose to do or not do. For example, a quote I can use is when we were able to tell someone, about their A1C and that they did in fact have diabetes, and they go, "Oh no, I don't claim don't claim that. I don't claim that sugar disease, you know. So there really are these other challenges, just a huge gap between what we know and then supporting the physician and supporting those families and those communities. And I just wanted to say that your science-based, your wonderful research is so necessary to support those physicians that have to face their little communities and their churches and their families and that world to be able to give the best care to those communities. So, you know, thank you again, but that's just kind of the background on the challenge.
Yeah, I mean, I think there are a couple of, obviously many things going on, many layers of that. And there's the, how do you communicate with patients? What is a patient's level of understanding? What is their willingness to accept information? There's also the physician's challenge of keeping current, right, with this new recommendations. And I've been thinking a little about this, and Frank probably might know of some projects underway that would use AI to be able to review patients' medical lists and comorbidities and identify issues and problems. Now, of course, you get alert fatigue, you get all of these other problems, but you know, I always wonder if that's a possibility.
Great. So one last question. I did a bottom line question for the PCMH. I'm going to do the bottom line question for you guys. You may have already given it, but I'm going to ask it again anyway, because I want to go on record. No, you're recording. I'm a family doc. Who should I prescribe aspirin to for primary prevention? Question mark.
I would say, you know, I want to say no one. I think you could make an argument that if you had somebody who was very high risk and was just about to have their heart attack or stroke, somebody who's, you know, has a risk that's in the 20% 10-year risk, something like that, you know, that might be a group to consider it in, because, but even in some of these studies, they had 10, 20% cardiovascular event risks. So Frank?
Yeah, and maybe a really, in one sense, risk-averse person who wants to do everything they can to try and avoid a, you know, cardiovascular.
Yeah, there
event.
are values. How much do you
Yeah.
value avoiding a stroke? You've just seen your father go through a stroke, or a family member. You might place a greater value on that than someone else. So I think that's probably, I agree, Frank, that's a better answer, is that.
I would add that I think that not all of our patients can afford those other medications for those other diseases. And so part of my bringing up the ethnicity and racial thing is that if you can't afford your medicine, it's probably still helpful for some of those patients. And again, we have to individualize based on their current circumstances, et cetera. But a lot of the medications you're talking about required for those other diseases are quite expensive. And if they can't afford even the copay, or if they're uninsured, aspirin may still be of benefit. They can afford it.
Thank you very much. I'm going to turn this back over. This was a great conversation. Both these were great. Thank you, Dr. Dankwa-Mullan. I'm going to turn it back over to Noah to take us out.
All right. Yeah, thank you again to our speakers today. This was a really great presentations and very engaging conversation. Thank you to our co-chairs for facilitating the discussions today. If you could please fill out the meeting evaluation, very brief, and just gives us some feedback about the event, and the link to that survey is in the chat. Our next Lunch and Learn discussion is in January of 2022. And that's, January 27th from 11 a.m. to 12 p.m. Eastern time. And we'll be sending meeting information closer to the meeting date. So I'd like to ask if Anne has any closing thoughts or reflections.
Thanks so much, Noah. And thanks to you and Irene and Jack for all the work that you're doing to make this a very successful forum. and such a rich conversation and discussion. At the Primary Care Collaborative, we continue to look at what policy can do to help support innovative models, every stripe of PCMH, if you will, because I think there are so many variants on primary care delivery reform. And we've looked at the research and talked to experts and think that one of the most important things that can be done to support care delivery reform that improves patient outcomes and eventually also bends the cost curve and addresses inequities is to invest more in these models. 5 to 7 cents on the dollar is paltry, and also to get off of the fee-for-service chassis. So that's the work that we're continuing to do. This research is so important to help inform policymakers and to help us make an evidence-based case for the policies that we promote. So thanks so much. And we'll see you in January. Please invite your friends to join.
Thanks.